Hello, and welcome to this GI Connect podcast on gastric cancer. My name is Sam Klempner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'm joined by my colleague and international gastric cancer leader, Dr. Lizzy Smyth. Lizzy, I don't know if you want to introduce yourself.
Thanks, Sam. Thanks for the introduction. Hi, everybody. Thanks for joining us today. I'm Lizzy Smyth. I'm a GI medical oncologist in Oxford, United Kingdom. And thanks for the invitation to speak here.
So we're going to go through a couple cases that I think will highlight some current data and emerging themes, both in the non-metastatic and metastatic settings. So Lizzy, if you want to lead us off with your case.
Sure. So the first case that we're going to discuss is an operable localized gastric cancer. So the case is a 68-year-old patient presents with dysphagia, difficulty swallowing, and a 3-kilogram weight loss. So this is our fairly typical patient. Endoscopy shows a circumferential tumor at the gastroesophageal junction, and biopsy shows a poorly differentiated adenocarcinoma. Patient has a past medical history of reflux, also very common, and he is an ex-smoker, but quite fit. Family history of a mother having breast cancer in her 70s. Exam, totally within normal limits. Routine staging of a CT-TAP shows a T3N1 tumor, and PET shows no metastasis. So here we are with a locally advanced junctional adenocarcinoma. Sam, I would like to ask you, what's your practice? What biomarker should we absolutely test in locally advanced GE junction cancer or gastric cancer?
Yeah, it's a great question and very topical, and probably I may have a different answer in a couple of years when maybe we'll have more biomarker-directed therapies in the non-metastatic setting. But I think over the years that we've learned, and you've led some of this work, certainly the microsatellite high or the MMR deficient patients is a somewhat different subgroup. Not only do they have an intrinsically better prognosis, but of course, from the metastatic setting, we've learned that they are, in general, substantially more sensitive and more likely to benefit from immune checkpoint inhibitors. So our institutional practice, and I think something that should strongly be considered internationally, is the need to test all localized or locally advanced gastric and GE junction cancers for mismatch repair status. At our institution, we do test for HER2 and PD-L1 in the non-metastatic setting, but admittedly are not routinely acting on those biomarkers.
I do think that's the key. So although, as you say, in a couple of years, it's likely that we'll be testing for HER2 and PD-L1, at this moment in time, we're not acting on those for our patients who are going to have surgery. MSI or MMR is slightly different because it impacts on the prognosis of the patient, on the likelihood of that patient to benefit from chemotherapy. So I do think that that's useful information to have. And we do recommend it for stomach and junctional tumors. We know that, the distal stomach cancers are more likely to be MMR deficient, but we also see a small proportion, maybe 3 to 4% of junctional adenocarcinoma being MMR deficient. So I think it's important to recommend the test, and that's independent of whether the patient has a family history, because we know that most MMR deficient patients with gastric cancer are sporadic rather than genetic. So we do an MMR test for this patient, and it's MMR proficient, as most patients are. So I would like to ask you, Sam, what would your preferred treatment approach be for a fit 68-year-old gentleman with an operable GE junction, which is node positive? So we've got a T3N1 tumor. What would your approach be?
Yeah, so this is a very typical something that we would see in the clinic. You have a clinically node positive patient, stage 3 clinically. And really, what do these patients die of? What is the main problem? Well, node positivity is obviously a marker for risk of distant metastases, which is the main cause of death. Most of our patients die of recurrent disease. So really strategies that are geared towards addressing occult micrometastatic disease and reducing the risk of recurrence, which in my opinion is really dependent on the activity of our systemic therapies. And perhaps one of our most active systemic therapies is FLOT, So our general approach to a fit stage 3 patient with node positive GE junction cancer would be active systemic therapy with FLOT, as was studied in the FLOT4 trial. We sometimes will have investigator or industry sponsored trials to address this population. There's certainly a need to improve upon FLOT, and even at ASCO just a couple of days ago, we saw an early press release about the Matterhorn trial, which is exactly trying to build on FLOT by adding immune checkpoint inhibitor in the neoadjuvant and adjuvant components of FLOT. But to answer your question, our standard approach in this situation involves active systemic therapy and evidence-based care with FLOT-based approch.
Thanks, Sam. And I think we would be very much in line with that. So I think we should also mention that there is another standard of care, which is frequently used, and that's chemoradiotherapy. So we have two choices in this setting: FLOT, perioperative chemotherapy. And as I tell my patients, we cure about half of patients who we treat with FLOT and surgery. And then there's chemoradiotherapy, as you mentioned, based on the CROSS trial, which also cures about half of patients. But we do get this sense that in CROSS, there was squamous cancers and adenocarcinoma, and the benefit is much greater for squamous cancers with chemoradiotherapy than for adenocarcinoma. And I think what's been really key for me over the past year is to see the 10-year follow-up of CROSS, which showed, in fact, that distant metastases, which you were relating to, were not reduced by the chemotherapy in CROSS. So we know that with CROSS, we've got relatively little chemotherapy for about 5 weeks, given on a weekly basis. It's really acting as a radiosensitizer, and it's allowing that high path CR rate that we see with chemoradiotherapy. But what we don't see is that reduction of micrometastatic disease and distant recurrence. So I completely agree with you. For node positive patients, I think that perioperative chemotherapy is a better choice. I would say that they haven't been compared yet in clinical trials, and we do have the ESOPEC trial coming up maybe in the next year or so to tell us which of those options is better or whether they are equivalent. You mentioned the Matterhorn trial, and that's just been presented at ASCO. So where do you think we're going with, first of all, immune checkpoint inhibitors, and then maybe targeted therapy in the perioperative setting?
Yeah, I think this is really the way forward for our tumor type of interest. So we know that with appropriately selected targets and patients in advanced setting, we can improve the survival by incorporating checkpoint inhibitors or targeted therapies or even combinations thereof, like in Keynote-811, where perhaps you're leveraging both potential advantages of targeted and immune therapies, and maybe even some cooperativity between the two. I would only make one additional point about the management of the earlier cases, that I think a lot of us recognize how difficult it is to give FLOT in the adjuvant setting, and we will sometimes tweak and give like 6 up front and 2 out back, as opposed to the 4 and 4 that was studied. Admittedly, there is not as much data for that, but I think in practical management, sometimes we will do that. But to answer your question, I think it really comes back to the idea of doing all we can to address systemic disease. And neoadjuvant immunotherapy has some biologic rationale. When the tumor is in situ, there is a more diverse T-cell response, as we've seen from some other tumor types. And certainly the clinical activity with neoadjuvant checkpoint inhibitor is quite promising. So I expect that most of the strategies will push on the neoadjuvant component in maximizing the effectiveness of our therapies there. I suspect all of the biomarkers that have been explored and are being explored in the metastatic setting, including the emerging ones of Claudin 18.2 and FGFR2, which I know you've been involved in for a while, will hopefully move into the non-metastatic setting with the idea that we can take the activity in advanced disease and translate that to earlier stage disease. Of course, we have to prove that and do these important trials. And I really do think that that's going to be a big part of the pathway forward.
I agree. I think that we're going to have quite an interesting time and hopefully help more patients as we introduce these treatments into the perioperative setting. As you said, we're there in metastatic disease. But right now, just to be clear, for HER2 and PD-L1, we're not using those targets in the perioperative setting because we don't yet have the data. We're waiting for the readouts from the trials. We've seen data on pathological complete response, but not yet data on event-free survival or overall survival. So we're waiting for those, hopefully at some upcoming meetings before practice can change. So we've talked about that standard case. Let me prod you a bit on what you would do for selected populations. You've mentioned already, of course, that you're kind of leaning towards a total neoadjuvant approach. And I appreciate that because we know that only 50% of patients tolerate their treatment after surgery. I think there is a few concerns about the total neoadjuvant approach, putting 8 cycles of FLOT up front in terms of neuropathy, perhaps, or deconditioning before surgery. But certainly that's something that's being looked at, and it's been very successful, for example, in rectal cancer, as we know. And there are also clinical trials looking at that neoadjuvant setting, like Critics 2, and other studies in development. So what about older patients? So we know clinical trials patients, average age 62. Non-clinical trials patients, average age 70s, maybe even a little older. What would you do if you've got, an 82-year-old with general comorbidities of an 82-year-old? He presents with the same disease. Do you change your treatment? Are we concerned about FLOT in older patients? Do we use more chemoradiotherapy? What's your approach?
Yeah, like all of oncology care, this is, of course, a shared decision-making with the patients, and our job is to introduce the options and provide a balanced assessment and realistic expectations of what each strategy might achieve. I think the principles are still broadly similar in terms of trying to reduce the risk of recurrence by acting on the systemic disease, but the way to get there may differ a little bit. As you suggested, we have seen that FLOT can be given safely to fit older patients. Age itself is not a clear criteria, but comorbidities and toxicities do increase with age, and we do know that FLOT is more difficult to tolerate, perhaps in some of this patient population. I would say in the real world practice, we will sometimes lean towards a little less of the upfront chemotherapy. I've considered platinum doublet as opposed to the triplet with FLOT in some cases, and perhaps a more CALBG 80803 like approach is something we will often consider, where it's, for example, FOLFOX followed by imaging, followed by consideration for chemoradiation. And I think the potential advantages of this strategy, one, we know that there's clinical activity from the trial. And two, in case the patient does not go to surgery or chooses not to go to surgery, in this case, because of toxicity or patient preference, you have, in that scenario, given definitive therapy in the form of chemoradiation. So you're a little bit buffered against what to do in case the patient chooses not to go to surgery. Perhaps I would say globally, a little bit more of the cross-based approach in the elderly patients, and that's certainly a very evidence-based and phase 3 data supported approach. So absolutely nothing wrong with that. I don't know, what is your practice in the older patient population with comorbidities?
So I think that actually, when we're in our upper GI MDT, the biggest stressor for any patient is the surgery, So the bottom line is, if a patient is suitable for an esophagectomy, I feel that they'll probably tolerate chemotherapy. Now, that doesn't mean that I'm going to give 100% FLOT. So for patients over the age of 75, I will try FLOT, but I'll routinely reduce the dose by at least 20%. And as you say, really need a clear focus on toxicity as we go along and keep a very close eye on them. I think, as you say, for me, if they're node positive, maybe chemoradiotherapy is going to be less effective. But maybe when we get into the super elderly, thinking about chemoradiotherapy with that view to definitive treatment, if we're concerned that they won't get through surgery, that's a very appropriate approach. So I think we need to be flexible and approach this based on the individual. And, we can have a fit 85-year-old and a less fit 50-year-old, and we approach all our patients as individuals and try and give them the best treatment that they can and make those decisions with them. So another cohort of patients. We touched on MMR deficient patients a little while ago, and we're routinely testing for that. We've seen amazing results for the neoadjuvant treatment of MMR deficient patients with nivolumab and ipilimumab, and also durvalumab and tremelimumab in 2 trials, Neon-PIGA and Infinity. What do you do with your MMR deficient patients? So are you tempted to use neoadjuvant immune checkpoint inhibitors?
Yeah, I find this data very compelling. Both the sort of pooled meta-analysis suggesting a lack of benefit from perioperative, in this case, MAGIC or adjuvant strategies, such as classic. Certainly FLOT was not included in that meta-analysis, but I think the totality of the data is suggestive strongly that these patients derive less benefit from chemotherapy-based strategies. They clearly have a more favorable prognosis overall. And the data with the neoadjuvant trials that you mentioned is like really impressive. I mean, to see 3 months of neoadjuvant immunotherapy in the Neon-PIGA trial yield pathologic complete response rates of 60% and major path response rates into the mid 70s. I know it was early reporting, but if you look at the event-free survival curve, it's basically a flat line. I mean, we would love to see something like that for more of our patients. So not only am I tempted, but we actually routinely do give neoadjuvant immunotherapy to this patient population. We also discuss upfront surgery and consideration of adjuvant immunotherapy or just observation and surveillance, because the surgery is, of course, a major event, but immunotherapy is not completely without side effects. So subjecting someone to a year of adjuvant immunotherapy when they may do quite well with surgery alone is a discussion. But yes, I feel that IO needs to be part of mismatch repair deficient localized disease. We tend to give it in the neoadjuvant setting whenever possible.
I am so happy for your patients and so jealous that you are funded to give neoadjuvant immune checkpoint inhibitors. That's fantastic. We're not funded here in the UK for that. And I think we'll need to wait for larger trials, unfortunately. But you're right to say that the patients with MMR deficient cancers might just need surgery, and their prognosis is really pretty good with surgery alone. Certainly platinum and 5-FU chemotherapy does not appear to be effective. I would say that for the patients who we need to downstage and we don't have access to immune checkpoint inhibitors, the data from a small cohort of FLOT-treated patients who are mismatch repair deficient was not bad. So don't forget, we've got a taxane in FLOT mismatch that is working on a different pathway in the cancer cell, and the mismatch repair deficient tumors appeared to be a little less resistant to that. They have good pathological complete response rates with FLOT. So my gut feeling when we don't have access to neoadjuvant immunotherapy is if the patient does not need to be downstage, for example, if it's a distal gastric cancer and the patient's a little older, straight to surgery if we can. If the patient does need to be downstaged, for example, a junctional cancer, FLOT is probably the best way forward. And if we can enroll our patients in trials with checkpoint inhibitors, all the better to try and get to those excellent pathological complete response rates. And I guess the next step will be, do we need to do surgery? Because, to a degree, they're already there in colon cancer, thinking about a non-operative approach. I think that's very experimental for now. But do you see that being the way of the future?
Yeah, I do. And I think, this could get even a little bit more confusing when we have data for like Keynote 585 and Matterhorn and have the MSI patients in there, because they're probably going to do great. And then you're going to wonder if it's chemo plus IO or IO alone. But yes, I think stratifying and teasing apart the patients who do exceptionally well after neoadjuvant therapy and may be able to move forward with a non-operative approach is a key question to the field. certainly, I believe there's an arm of the Infinity trial that is addressing this question, which I was really great to see. And that's a wonderful trial being run by our Italian colleagues. The tools we have right now are probably not routinely good enough to tease apart those patients yet, meaning PET scans, endoscopic assessment with maybe bite-on-bite biopsies to look for complete clinical responders. And ultimately, this is a place and an opportunity for plasma-based approaches like cell-free DNA. And I know you've had some nice papers about looking at the prognostic performance of ctDNA, and it's been an interest of ours as well. So I think, yes, that's definitely the direction. We just need to get better at teasing apart these patients so we don't forego a curative procedure in someone who needs it
and would do very well after it. So I do think it's a fascinating question. Of course, the patient needs to be involved in these decisions because a gastrectomy is a life-changing operation. So if we can avoid it in future, I think that that's something that's definitely going to be of interest. You have just mentioned ctDNA, so hot topic. You and I have both done research on it. And so I'm going to put to you a little part of this case and ask what you would do next. So our hypothetical patient we've been discussing, they've had FLOT, they've had their surgery, and they've tolerated it pretty well. The postoperative histology is YPT2N2. So they've got 3 lymph nodes involved. They've had a decent lymph node resection, 42 lymph nodes out. So what would you do next for this patient? Are you routinely using ctDNA? If not, why not? Should we use it? Where do you think we're going to go with that?
Yeah, so I mean, this case highlights a lot of things, and I'll try to be quick, but yeah, certainly high risk residual node positive disease after surgery. We know these patients are at high risk, I think, of recurrence. ctDNA can even further refine that risk. So it's pretty clear to me from your work and our work and others that patients who are ctDNA positive in the period after surgery, whether you define that as one test draw, a couple draws within the first 2 months or whatever, those patients are at exceptionally high risk of recurrence, probably upwards of 80% or more. And that just tells you that, 1, we have a relatively sensitive test, and 2, that this is a conserved, poor prognostic biology. These patients presumably have micrometastatic disease somewhere. The question of what to do about it is the million-dollar question. So we know that we need to worry, and these patients are at very high risk, but we don't yet have data to tell us what is the best thing to do. Certainly, we would try to offer this patient the adjuvant component of FLOT. That would be the routine standard of care. It's tempting to consider other strategies, but admittedly, we don't have large data sets to say non-cross-resistant chemotherapies or adding IO really improves outcomes. So we are doing ctDNA in these scenarios, partly to build the global data sets that will help us guide the future in terms of designing some of these trials for, particularly high-risk subsets like ctDNA positive. But admittedly, we are not routinely guiding management based on ctDNA in this setting yet.
I agree. So I think that we're a little bit maybe behind colorectal cancer in this sphere in terms of the trials which have been done. We have reasonably sized data sets, but very little collected prospectively. I'm really delighted to hear that you're testing in Mass General ctDNA. I'm interested, without getting super technical, which assays do you think we should be using? Should we be using personalized assays, or should we be using non-personalized assays? I haven't seen a huge amount of difference between them yet, which really surprised me.
Yeah, I think, the technological and analytical aspects of these platforms continue to improve and will probably incorporate even other features, methylation, proteomics, et cetera. And I think that both platforms will achieve, high sensitivity and specificity. The issue in my experience with disease types where patients get a lot of neoadjuvant therapy is that to build a patient-specific assay, at some point you need tissue for generally whole exome to benchmark and define the variants you're going to track. And if the only tissue you have is a small endoscopic sample at diagnosis, and then hopefully the patient has a good pathologic response at surgery, there are cases where you just won't have enough material to build the test. And this may be an opportunity for plasma-based assays, although I do expect that the tissue-based platforms will continue to get better with, smaller input values and things like that. But I think those are sort of some of the questions that may guide you towards one platform or another.
I agree. I think that we're still evaluating, aren't we, currently? I would say the question is easy for almost for the ctDNA positive patients, those patients who are at high risk of recurrence. So we are definitely going to treat them if we can. The question is, should we be evolving other treatments than FLOT? And how good is FLOT for those patients who still have residual disease based on ctDNA after surgery? I don't think we know the answer to that yet. But what I do think is possibly it gives us an opportunity to bring some of these very effective and powerful new drugs that we're using in the advanced disease setting maybe a little bit earlier into treatment. So, for example, I've got a study coming up with trastuzumab deruxtecan in ctDNA positive patients. And I'd be really interested to understand whether we can use ctDNA, a fall in ctDNA, as a measure for how effective the drug is. And it could give us an opportunity. Traditionally, drug development has been done in patients who are very refractory to treatments, and they may have a different biology than patients who've just had surgery. And I think it does give us an opportunity perhaps to help patients at an earlier stage in their treatment pathway. But those are all interesting questions. I don't think we're there yet, but certainly something to keep an eye on over the next couple of years. So I do hope it will offer us an opportunity to help patients actually with minimal residual disease. And I think that we will hopefully be classifying these as a separate group in future in whom we can possibly cure micrometastatic disease with the right treatments, but we'll need to return to that subject after a while. So that's been a great case. That's been a really detailed discussion of a perioperative case, moving through their treatment journey with FLOT, with postoperative treatment, thinking about biomarkers. Is there anything else you wanted to add to that, Sam? Any final thoughts in the operative setting?
No, I think it's getting into defining the patients who are benefiting, teasing apart the groups that we can approach differently, and really testing for MMR deficiency, I think, is the key thing that you can implement in practice like right away as a way to identify a group that maybe we already can manage differently. So I'm going to take us through an advanced case quickly. I know that you've touched on a lot of the themes here, but this is a relatively recent case, and hopefully will illustrate some points in the advanced setting. So it's a young woman, 56-year-old woman, presented with fatigue and anemia, found to have a 4-centimeter gastric fundus ulcer on endoscopy. Biopsy confirmed this is a moderately differentiated adenocarcinoma, fit patient. Really minimal past medical history, just some baseline hypertension and glucose intolerance. Patient is anemic, family history, really non-contributory here, no GI cancers, no physical exam findings. Patient has diffuse lymphadenopathy above and below the diaphragm on baseline staging scans and 3 liver lesions. So we have a patient with a de novo advanced gastric cancer. What more do you want to know specifically? What biomarkers do we absolutely need to know? And how are you approaching biomarker testing for the routine patient?
Thanks, Sam. So we have the biomarkers that are essential to have, and then we've got those that are nice to have. So for all of my first line patients, most critical for me is MMR, then HER2, then PD-L1. And all of those have an influence on treatment. The reason why I think MMR is the most important is because we cannot miss the opportunity to treat these patients with immune checkpoint inhibitors, either with or without chemotherapy, because they're quite likely to have an excellent response, even to monotherapy, and to have long-term survival with access to immune checkpoint inhibitors. So MMR, number one. And so I usually prefer to test the IHC. We get the result back in a day or two. And so we have the information ready before we make a decision on treatment for the patient. HER2, an oldie but a goodie. We've been doing it for about 10 years now. And in certainly in Europe, this is retaining eligibility for trastuzumab for HER2 positive patients. We don't yet have access to trastuzumab and pembrolizumab as you do in the States based on the results of KEYNOTE-811. We need to wait for the overall survival data from that trial. And lastly, PD-L1. So PD-L1, we test for eligibility for immune checkpoint inhibitors in Europe and the UK. Patients are required to have a CPS score of 5 or greater. That's a little unlike the United States and Asia, where patients with any PD-L1 score may be treated, although I gather that you might choose not to treat patients with a CPS score of under 5. Is that right?
Yeah, so ASCO recently came out with sort of practice guidance, I guess a little more geared toward US practice patterns that I think is relatively aligned with sort of EMA guided approaches. So clearly the greater than 5 population are deriving the greater magnitude of benefit. And if it's greater than 5, yes, clear, the answer is yes. If it's totally negative, as in less than 1, we routinely do not offer checkpoint inhibitors. And in the 1 to 4 group, I think that there's a lot of variability, and we could have a whole podcast about what antibody clone you use, what site you test, how do you interpret it, what do you do with a 3? Is 3 really the same as a 6? So this is really an individual discussion, and I'd say I've certainly used it in patients between 1 and 4, and it's variable. I try to be consistent. Just out of curiosity, what test are you using for PD-L1 at your institution?
Interesting. So we are using 22.3C. I just moved institutions though. So
Yes.
Previously I switched from 22.3C to 28.8, although we have access to both. And the reason why I switched to 28.8 because data last year suggested that 28.8 might pick up a few more patients to be CPS high or checkpoint eligible than 23.2C. If I'm honest, based on my clinical practice, I haven't seen a whole lot of difference. When that data emerged last year to suggest that 28.8 was more sensitive, I sent a bunch of patients back to be retested. And I did find one patient who came up as checkpoint eligible based on that, but that could have been heterogeneity rather than the assay. So we don't really know. I will say we could talk about this all day, couldn't we? But ultimately, I agree with you. So, if you'd asked me 2 years ago, I would have been totally only CPS 5 should be treated. But I've seen so much data on the variability of these assays now and interpathologist variability. I don't think we can say a CPS 4 is not a CPS 5. I think that's very difficult. So I think that we're going to need to work on this a little bit more in the next couple of years and understand where those gray areas are, because I think what we don't want to do is miss out on treating the patients who might be helped by immune checkpoint inhibitors. Just going to plug a trial that I'm doing at the EORTC then, where we're going to take a big cohort of patients and do a kind of blueprint study like was done in lung cancer, looking at maybe 200 patients, PD-L1 scoring using the different assays, and score those with a large group of pathologists and understand where the challenges are and how we might move forward. So ask me again in a year, I might give you a different answer.
Definitely will ask you again in a year. All right, let's make this a little bit more complicated because this might be the real world within the next months even. So imagine zolbetuximab is approved. What else are we going to need to know about this patient to potentially guide even another option?
Okay, so zolbetuximab is a Claudin 18.2 antibody, monoclonal antibody. It's just demonstrated improvements in overall survival in 2 studies, so Spotlight and GLOW, that used FOLFOX and CAPOX variably in Claudin 18.2 positive tumors. So we're going to need to get working on those Claudin 18.2 IHC tests. So I think the cutoff in the trials was around 70 or 75% of cells being positive. Is that right, Sam?
Yes, 75% the cutoff for GLOW and Spotlight, exactly.
And that captures about 40% of patients, if I'm right. So we're going to have 40% of patients who are Claudin 18.2 positive and might benefit from zolbetuximab. We're going to have 40% of patients who are PD-L1 high, let's call it, and might benefit from immune checkpoint inhibitors. And so the question will be, what's the overlap? Is there one treatment which is better for the patients who are PD-L1 high versus Claudin 18.2 high? I don't think we have the answer for that, but I do remember that Kohai Shitara presented a little bit of data on the PD-L1 versus Claudin 18.2, didn't he, in GLOW? Can you remember that?
Yeah, I think it's a little bit tricky. Personally, I almost think this is like a new type of biomarker. This is really a lineage-specific marker. You're kind of marking tumor cells, not so much defining a biology like HER2 or MSI high. So really interesting for the field, kind of like TROP2 is like a lineage marker for just tumor cells itself. In the studies in the phase 3 trials, there was perhaps a lower than reported CPS high population. And it may have been that, we get PD-L1 results quite quickly, and therefore there was sort of a pre-selection against some of those patients, I think, to be determined. But from retrospective data, it almost looks like Claudin positivity and negativity sort of runs through every other biomarker subgroup at equal frequencies. And this sets up really interesting situation. Like you said, we have a very prevalent biomarker at around 40%. And so we're probably going to have like 40% of HER2 positive patients are going to be Claudin positive. And then what are you going to do? And as you suggested about PD-L1 as well, certainly the sort of obvious path forward is kind of do the KEYNOTE-811 strategy and combine the immunotherapy with the monoclonal antibody and chemo. And that's a strategy that is actively being pursued. So let's make this a case of exactly that scenario. So let's say you have a CPS3 and a Claudin 18.2 positive patient, and you have all the tools available. Are you going to give the Claudin first in that scenario? And would you be different if it was, let's say, a CPS of greater than 10, where you have an obvious, it's a very positive patient?
Wow, you made that question too easy for me, because I can only treat patients with PD-1 inhibitors if their CPS score is 5 or greater. So if the patient has a CPS score of 5 or greater, I think that is the group that benefits most from immune checkpoint inhibitors. So I would be comfortable treating them with an immune checkpoint inhibitor first. Although I do caveat that with the median overall survival in Spotlight being better than we saw in any of the immune checkpoint inhibitor trials. But I think there are aspects to that may not relate directly to zolbetuximab. So I think that I would be satisfied if the CPS score was pretty high to go ahead with the immune checkpoint inhibitor. But perhaps if it was lower, 3 or 1, I think the jury's out. One thing that I would mention is that the zolbetuximab is very well tolerated. I know that there are some concerns around nausea, but certainly I treated a bunch of patients on one of those trials, and we found the nausea quite manageable with NK1 antagonists, and we use a lot of olanzapine. And so nausea, I think if you address it early on, dissipates fairly quickly. So it certainly wasn't a challenge for me for patients I treated on the study. I don't know what your direct experience was, Sam.
Yeah, I agree. I think like any new drug, a little bit of a learning curve, similar to we had with, TDXD. First few times you give it, you get a sense. But I agree. I think after a little bit of experience and playing around with, perhaps interrupting the infusion if the nausea was significant, we can get patients through this. And it's hard to ignore 2 phase 3 trials with survival benefit when we're picking therapies for our patients. So I agree. I think this is a manageable toxicity for patients, and otherwise the drug is quite well tolerated. Let's say this patient gets FOLFOX and zolbetuximab, and I'm projecting forward maybe 6-12 months of our clinical practice lives. So this patient gets FOLFOX and zolbetuximab and ultimately progresses after, let's say, 7-8 months, otherwise still remaining fit. How do you think we're going to think through second line? And are you going to biopsy and look at Claudin expression again, kind of like we do for HER2 sometimes? So
I think that you raise a brilliant question. And I just going back to what you said earlier, I totally agree that we're in a new era of biomarkers. So Claudin, it's not an oncogene. We're not targeting it. It's a passenger on the gastric cancer cell. So that we don't know whether we're going to get loss of the antigen over time. We don't know the mechanisms of resistance. But based on what we learned from HER2, because you look at 10 years of failed HER2 studies of gastric cancer, and what we hadn't done was done a biopsy to see if the HER2 was there. So what we need to do, I think, is explore pretty quickly what the resistance mechanisms will be. But what I would like to see, and what I see coming, is with Claudin and with all of these targets, is that we should be doing repeat biopsies. I mean, breast cancer doctors have been doing this for years. And what is going to benefit patients most is sequential treatment. So especially with Claudin, we've got a lot of very exciting drugs. We've got the antibodies, they've got there first, and we're going to use those with chemo, possibly with IO, as you mentioned. But we've also got lovely ADCs, bispecific T-cell engagers, and then CAR-Ts, very exciting, very preliminary. But I think the patients are going to do best if we sequence these over the course of their treatment. But first of all, we need to understand if the target is still there. So I think what we need to do in future is make friends with our endoscopists, with our interventional radiologists, and discuss patients why they benefit from biopsy. So this is going to be something that is going to be what we do in future.
Yeah, I'm going to go back and get a IR fellowship so I can just.
All we need is an ultrasound, right? Yeah, so we get an ultrasound and a couple of tutorials from our IR colleagues.
Yeah, I mean, I think you raise an important point that some of these protein markers are not really well suited to liquid tests, and so the biopsy will remain important. I know we're running low on time, and it's always easy to talk to you, and I'm sure we could, keep talking for a long time. But I am going to wrap us up so that people listening can get back to their days. So maybe to close, I think the key themes that you mentioned, and feel free to expand on, are, again, biomarker testing in the advanced setting, teasing apart the overlap, which I think is the task of all of us who do research in this field for the coming years. And then sounds like the good news message of, more targets coming. Zolbetuximab, we expect some approval. We have bemarituzumab, an FGFR2 directed therapy, and many other subsets that will be coming forward in the hopefully near future. I don't know if you have any other messages you want to get across in the advanced setting.
I think that's it. I think you've summarized it really lovely. I think, esophageal and gastric cancer have always been difficult cancers to treat. And I think that we're on a kind of event horizon now where we've seen the access, the availability of these new targets. We've seen really good data. We're starting to see good data for PD-1. We'll see the next generation of immune checkpoint inhibitors come in, Claudin 18.2, combining that with PD-1, FGFR2b, the same, HER2, next generation HER2 inhibitors. And then we've got our cellular therapy. So, lung cancer, 10 years ago, the survival was less than a year for most patients, sadly. And now you've got 30% 5-year survival. So I very much hope that we're heading in that direction. And it's going to be about participating in clinical trials, understanding the biopsies, and again, always focusing on the holistic needs of patients. With esophageal cancer, we can't get away from that. So nutrition and dealing with their symptoms. But I think that the future is looking bright.
Yeah, well said. And hopefully this was educational for everybody listening. And I definitely look forward to the next time we meet in person and talk online.
Thanks, Sam.
Thanks, Lizzy.